Good afternoon and welcome to the second medical update of this year. Today's web-based seminar is called Pitfalls in the Diagnosis and Management of Tuberculosis. My name is Rajitha Bavaraj. I'm a training and consultation specialist at the Rutgers Global Tuberculosis Institute at the TB Regional and Training Consultation Center for the Northeast United States. Today's program is sponsored by the Institute. The objectives for today's presentation are on this slide. This web-based seminar for clinicians will move beyond the basics of TB management and focus on some of the challenging characteristics of TB presentations and manifestations, which may complicate and at times delay the diagnosis and treatment. Case examples will be included to illustrate these complexities. In addition, speakers will share experiences on how to manage such cases using existing resources. Our faculty today are Dr. Catherine McGowan from the Shattuck Hospital in Massachusetts, Dr. Ami Patrawala from here at Rutgers University, Dr. Elizabeth Talbot from Dartmouth, and Dr. Marie Turner, also from the Shattuck Hospital. All of our faculty today share a wealth of knowledge and expertise in today's topic. The seminar today will consist of several parts. After this introduction and some brief housekeeping details, Dr. Patrawala will start us off with some background and an overview of some of the challenges that can occur when diagnosing TB. Then, Dr. Talbot will illustrate some of these challenges with an interesting case of TB meningitis. We'll then hear from Drs. McGowan and Turner with some additional interesting cases to further address some of the important issues in the management of TB. If there is time, we will end by responding to your comments and questions. Now, I'd like to turn the program over to Dr. Ami Patrawala. Dr. Patrawala will be presenting the first talk on the pitfalls in the diagnosis and management of tuberculosis. Dr. Patrawala?
Thank you, Rajitha. And thank you for inviting me to speak today, and welcome to all of the attendees. So I'm going to start generally by reviewing some of the potential challenges you might encounter in diagnosis and management of tuberculosis, and then go into some more specific scenarios with some cases interjected that hopefully will be helpful to you. So in terms of diagnosis of TB or tuberculosis disease, I think number one, we all have to realize that, especially in the U.S., as the number of cases are falling, we have to continue to maintain a very high index of suspicion. Certainly, I think all of us pay a lot of attention to those patients who fall into our usual risk groups, so patients who are coming from outside the country where the risk of tuberculosis is much higher, patients who have HIV, and other such risk groups. However, one thing to realize is that other risk categories are growing in prevalence and becoming groups where we see a fair amount of tuberculosis. So some of these diseases, which are quite common, are things like diabetes, where the risk of TB may be as high as 3 times that of a person who's not diabetic. Certain autoimmune diseases, especially because we're using a lot of biologic agents to treat those diseases, such as TNF blockers or tumor necrosis factor blockers, that may increase your risk of tuberculosis. Certainly patients both who are pre- and post-transplantation are at higher risk for TB, and we're certainly seeing more of those patients as well in this country. And also chronic kidney disease, which is a very large group of patients in this country and a growing group, and those that we see less frequently, but we do still see those that are malnourished. And along with maintaining this high index of suspicion, we'll talk a little bit more about this, but we also have to realize that just because the sputum smear for acid-fast bacilli is negative, that by no means rules out tuberculosis disease. And in fact, as we'll see later, up to 50% of patients with pulmonary TB will be smear negative. Extrapolating on this or going a little bit further with this, there are certainly settings where diagnostic delays in terms of tuberculosis are much more common, and that's certainly in populations with HIV, also in extra-pulmonary tuberculosis, which we'll talk about more, and then in this larger category of patients who have smear-negative disease. And I think these are settings where we have to be particularly vigilant. So, one thing to consider when you're trying to diagnose somebody with tuberculosis, and often this is an afterthought, but we really have to do a very thorough microbiologic workup in those cases, especially if the case appears atypical or unusual. This may actually require multiple or even repeated diagnostic procedures, often invasive procedures if we're talking about extrapulmonary disease. And often when we're doing invasive procedures, we don't routinely send cultures on those specimens, and so that's something to consider when you're planning your diagnostic workup. And of course, there are many resources available. Your local as well as regional public health authorities as well as TB experts can help quite a bit in assisting with TB diagnosis in these less usual circumstances. So putting it all together, TB diagnosis really rests on multiple different evaluation tools. So our microbiologic tools are clearly one part of that, but again, by no means are going to be 100% useful to you all the time, and you certainly need to know the limitations of the tests that you're using, especially some of the more rapid tests. Imaging can certainly help, and I'll show you some examples of that, especially when we're talking about extrapulmonary TB. But I think your diagnosis is really going to rest primarily on the patient's risk factors, their epidemiologic risk factors, the local epidemiology in your community, and knowing who is at highest risk in your community, and ultimately your clinical suspicion for TB disease. And if you have very high clinical suspicion but no positive cultures or no positive microbiologic assays, that certainly doesn't mean that they can't still have TB, and that's something you should consider. So what about TB management once you've already made the diagnosis? So number one, multi-drug therapy is certainly the cornerstone of TB management, and if the patient cannot be on a reliable multi-drug regimen, you really have to consider that all medications should be held until you can come up with an appropriate regimen for that patient. We certainly use directly observed therapy in pulmonary TB, but there are certainly more complicated cases involving extrapulmonary TB or patients with significant other comorbidities like HIV, where DOT may be especially useful and improve the outcome in those patients as well. So if it's feasible for you, I would highly consider that. We stress very highly that you should closely follow patients with TB disease. You have to pay very detailed attention to their symptoms, imaging, their microbiology, their drug susceptibilities, as well as laboratory monitoring if that's appropriate for your patient. And one way that you could feasibly do this is with what's called a drugogram, where you can actually, if I can point this out, where you can actually enter the drugs that the patient's on, the durations that they're on and off the drugs. You can also enter their smears and their culture results, as well as their sensitivities, and this can certainly help you track the patient and help monitor the patient to see if they're receiving appropriate therapy and if it matches up with improvement in their microbiology. So that's just one example. I'm sure many of the people listening have different systems for monitoring their patients, and I think as long as it's a comprehensive system and it works for you, then I think that that's fine. We should be aware of adverse effects and drug-drug interactions. Patients are on multiple other medications oftentimes and have multiple other comorbidities that can be impacted by TB treatment. And so we certainly need to know what to expect when we put people on these regimens. I mentioned comorbidities. I think most of the patients I see these days with tuberculosis have multiple other medical problems that are also potentially unstable, and their TB treatment may impact their glycemic control for their diabetes. Their TB treatment may impact their blood pressure control if they're hypertensive, and certainly if they have HIV, we know that the rifamycins will interfere and interact with many of the HIV medications, many of the drugs that we use these days for transplant patients. And so all of this really needs to be discussed with the patient and needs to be followed. And I think to that end, open communication with the patient's other healthcare providers as well as the public health authorities and any hospitals that may be involved is also really key. And I think most important on this entire slide is education in terms that the patient and caregiver can understand. Repeated attempts at education in multiple different forms by multiple different healthcare providers is really important. I think if the patient understands what to expect as a result of some of these medications and some of the side effects they may have, their care will be much smoother and they'll be much less likely to default. Okay, so I'm going to move on now to talk a little bit more specifically about some of the things that I've already mentioned, and I'm going to use some cases that I've seen in the past few years to hopefully try and highlight some of those points. So this is the first case, and this is a gentleman I saw a couple of years ago. He's a 29-year-old Indian man who presented with right leg pain, which he had complained of for about 4 years. He noted right ankle swelling in addition to the pain about a year ago and had been evaluated by our orthopedic clinic. He denied any other systemic symptoms. A little prior history, about 5 years previously, he had developed a cough and fever and weight loss while visiting Denmark from India, and he had been treated for pneumonia but did not have any improvement. He recalls that he was tuberculin skin test positive. He then returned to India, and his physicians there felt that he most likely had pulmonary TB, and he was started on a fixed drug combination pill, including isoniazid, rifampin, and ethambutol. And he states that he took all of these medications for 6 months, and he had significant clinical improvement. A year later, he then moved to the U.S., and several years later is when he developed his right ankle swelling and presented to us. So this is a plain film of his right ankle, and I think you hopefully can see here at the distal end of the fibula, there's an osteolytic region here in the lateral malleolus in the distal part of the fibula, as well as a little bit more subtle but some soft tissue swelling around it as well. And then he had a CAT scan as well of the same area, and what you'll notice here, again, this is the distal fibula, this is the distal tibia, and there's this sort of punched out area in the bone here with a large soft tissue mass surrounding it, and then you can also see some punctate areas of calcification here. So the concern at the time was that he had a malignancy, that he had a soft tissue and bony malignancy. So he underwent partial excision of his fibula and a deep biopsy of the soft tissue and the bone, and the findings during surgery were consistent with that. However, his final pathology revealed necrotizing granulomas. So if we look at the micro, the initial specimens were smear negative for acid-fast bacilli, and as we'll see, that's not really uncommon with extra-pulmonary TB. When we asked the pathologist to look back at the specimen, they were able to find in the tissue one solitary bacilli here, right in the middle. We requested a PCR on the tissue, and the MTB PCR was positive. And ultimately, several weeks later, all of the specimens grew tuberculosis, grew M. tuberculosis. So I think this is an example and a relatively typical example of how long it can take to recognize somebody with an unusual presentation of tuberculosis, even though this gentleman had many risk factors and had clearly had pulmonary TB in the past, which clearly, increased his risk for having subsequent episodes of tuberculosis, it can still be very challenging to make a diagnosis and often requires invasive procedures and collaboration between multiple different specialties. So extrapulmonary TB, I think, is one of those situations, like I mentioned earlier, that we really have to focus in on because in the U.S., extrapulmonary TB accounts for about a fifth of all TB cases that we're seeing, and this is quite consistent across other developed countries as well. Overall, in the U.S., the rates of TB are actually declining, but the proportion of extrapulmonary TB is actually increasing. In several studies that I've listed at the bottom of the slide, we've seen associations between extrapulmonary TB more frequently with women, slightly more common in individuals who are foreign-born, certainly in individuals of African or Asian descent, and certainly in populations that are more immunocompromised than others, including patients with HIV who actually have a higher risk to go on and develop disseminated TB, both pulmonary and extrapulmonary TB. Interestingly, extrapulmonary TB seems to not be associated with some of the risk factors that we would consider more usual or more traditional. So it does not seem to be associated with incarceration, alcoholism, or homelessness. At least not in the United States. And of course, extrapulmonary TB encompasses a large number of different organ systems. So meningeal and lymph node TB is seen frequently in children, whereas genitourinary and bone or joint TB is generally seen more frequently in older adults. In U.S.-born patients, meningeal and pleural TB seems to be more common, whereas lymph node TB seems to be more common in those that are foreign-born. And it seems that there are certain subpopulations that have a higher predilection for certain organ systems, and that's not really clear why. But for example, South Asians seem to present more frequently with lymph node TB. So this is a bar graph from a paper in the U.S. that looked at all cases of extrapulmonary TB that were reported between 1993 and 2006. The open circles here are the proportion of pulmonary TB cases. The white bars are the number of pulmonary cases, and as you can see, the number of pulmonary cases has been decreasing, and the proportion of all TB that's pulmonary has also been slightly decreasing. These are the extrapulmonary cases, and they've been relatively steady, maybe a slight decline, but as you can see, the proportion of extrapulmonary TB cases has actually slightly risen over the past 15 years or so. And a further breakdown of where we see extrapulmonary TB and the sites of disease show you that about 40% of all extrapulmonary TB is lymphatic, certainly with most of that, about a quarter, being cervical. The next largest category is pleural TB. And then after that, you see a smaller proportion of bone and joint, and even less frequently meningeal, genitourinary, and peritoneal. So our patient fits into this category with bone and joint disease, which accounts for about 11% of all extrapulmonary TB in the last 13 years or so, certainly more frequent outside of the U.S., where up to 15% or even higher of all extrapulmonary TB may be musculoskeletal. So this is an even further breakdown of what our patient had, which was musculoskeletal TB. And this is actually a study from the UK looking at all the musculoskeletal cases in one region over about 6 years. And I think this data holds true for what we see in the US as well, with the majority of musculoskeletal TB being focused on the spine. And then your larger joints are most prevalent after that, with the small joints, your wrist, fingers, and ankle, really contributing very small proportions of disease. And so I think what this tells us is that, again, we have to be really vigilant in these cases, because we may only see 1 or 2 cases in the U.S. So why is diagnosis of extrapulmonary TB so difficult? Well, one, it tends to be paucibacillary and much more difficult to detect on smear and even on culture. Again, diagnosis may require invasive procedures. It may require repeated procedures, and this involves a lot of collaboration across subspecialties. Some of the rapid tests that we use and that you may be hearing about more recently may be quite useful in this group of patients, and I think you're going to hear a little bit more about GeneXpert later on. But in a large cohort of patients in New York City, they actually looked at all of the nucleic acid amplification tests that they had done and found that the sensitivity in extrapulmonary disease was quite good, as high as 80 or 90%, certainly higher if the culture ended up being positive. If the smear ended up being positive. So your nucleic acid amplification test may certainly be useful in this group of patients. It's certainly easier to get the test done on a fresh specimen rather than waiting until the specimen has already been fixed and sent to pathology. So clearly something that if you can think about it while the patient is having the procedure and send it right away. And GeneXpert also seems to have good sensitivity and very good specificity in extrapulmonary TB, certainly in tissue and in certain body fluids, and I'm sure we'll hear a little bit more about that later on. In terms of treatment of extrapulmonary TB, it's really similar to treatment for pulmonary TB, except that most people would extend the duration of treatment up to usually around 12 months in meningeal TB or in CNS disease. And most of us would also extend treatment in bone and joint disease, usually to 9 months. And a lot of this has to do with theories about drug penetration into these areas, as well as the fact that it's really difficult to monitor these patients. Again, you're not going to be able to get repeated samples from somebody's bone. And so you may need to use other tools, certainly clinical symptoms, as well as imaging can be very useful. So just to summarize why there are so many challenges in diagnosing extrapulmonary disease, certainly fewer TB cases, especially in the U.S., has led to lowered suspicion overall for tuberculosis. Our public health focus is primarily on pulmonary TB because of the transmissibility, and so that may be part of the reason why we see more delays in extrapulmonary disease. As we've seen and as we've discussed, the risk factors differ between patients with pulmonary and extrapulmonary TB, and we may need to use different tools to identify those patients. The diagnosis, as we've discussed, is clearly more difficult and often takes much longer, sometimes months to years. And patients tend to present in a more indolent fashion, and so that definitely makes it more difficult as well. Treatment efficacy and culture conversion can be difficult to detect. And although this is a challenge, I think it's also a necessity that we really need to have a multidisciplinary approach involving multiple different specialties. So I'll move on to the next case. So this is a 29-year-old physician from Pakistan with a dry cough for 2 months. She had no fever, no night sweats, no weight loss, and she reported that she was TST negative 6 months previously. This was her chest x-ray, which shows bilateral upper lobe infiltrates with a sort of interstitial quality to it, with some volume loss in the right upper lobe. So her induced sputum was smear negative. Her QFT, or quantiferon gold, was positive. Because of our high suspicion for TB disease in this patient, given her x-ray and given her risk factors, she was started on multi-drug therapy for tuberculosis, and her cultures were positive about 4 weeks later. So I think this case illustrates what we were talking about with smear-negative TB. So a little bit on smear-negative TB. So Sputum smear microscopy sensitivity is about 50%. So again, if we rely on smears alone, we'll miss about 50% of cases. If your lab uses fluorescence, you may pick up a few more cases, but remember that it takes about 5,000 organisms per milliliter of sputum to be picked up by smear alone. And your smear sensitivity will be even lower in patients with HIV and in children. So smear-negative TB can certainly lead to both diagnostic and treatment delays. We see smear-negative TB increasing, especially in settings with a high HIV prevalence, and up to about 40% of cases in the U.S. that are reported are smear-negative. And I think even more importantly to recognize is that smear-negative TB in several studies now accounts for about 10 to 20% of all TB transmission. So smear-negative TB can clearly be transmissible. And so just because somebody is smear-negative certainly does not mean that they're not infectious. And again, in multiple studies, this number has been quite consistent that a patient with smear-negative TB results in about 1/4 the number of secondary cases as somebody with smear-positive TB. So clearly not as transmissible as somebody with smear-positive disease, but can clearly lead to quite a number of cases. And so again, in our case, had we waited 4 weeks to start her on TB treatment, we would have allowed not only 4 weeks for her disease to get worse and for her to develop symptoms, but also an additional 4 weeks that she may have transmitted disease. And I don't know if you remember, but she was a physician. She was actually an obstetrics resident, and the outcome, could have been very serious in that situation. So again, smear-negative TB is common and it is transmissible, so infection control measures are certainly necessary. We talked a lot about the treatment delays. Contact tracing is essential, but again, because of the diagnostic delays, it too can be delayed and lead to more transmission. Rapid diagnostic tests are moderately sensitive in smear-negative disease and may help mitigate some of the above. So both the nucleic acid amplification test as well as Gene Expert can be useful in this setting. And treatment is, of course, similar to patients with smear-positive TB. So I will probably finish with this last case, unless we have a few more minutes for the very end. But this is a 45-year-old woman who's currently incarcerated with a history of injection drug use, and she complained of cough, fevers, sweats, and weight loss for 2 months. This is her chest X-ray, which shows bilateral upper lobe volume loss, as well as some nodules here and here. And some pleural thickening and scarring here. And unfortunately, we did not have an old chest X-ray to compare this to. She was smear-negative multiple times because of her symptoms, because of her chest X-ray, and because of the fact that she was in a high-risk congregate setting. She was started on anti-tubercular therapy. Her cultures actually remained negative even at the end of the 2-month period, and she had minimal improvement on her chest X-ray, but she really had resolution of her symptoms. So I'm going to speak quickly about culture-negative pulmonary tuberculosis, which I think is something we almost never talk about. The clinical and radiologic picture is quite similar to active TB. However, your cultures remain negative, and this may be for several different reasons. The patient may have very few organisms, and they just don't grow in culture. The specimen processing may have had some problems with it. And there is an idea that there may be some temporal variation in bacterial shedding, so you may just not be picking it up at the right time. We should certainly at least get 3 good quality sputum that might require an induced sputum. You can consider other diagnostics such as bronchoscopy, although in several studies a BAL is not really any better than a good induced sputum. And in the U.S., of all the reported cases, it accounts for about 15 to 20% of reported cases in the U.S. And this is a treatment algorithm from the American Thoracic Society, CDC, IDSA joint statement from 2003. And if you look here, this is your at-risk patient with an abnormal chest X-ray whose smears are negative and you're highly suspicious for tuberculosis. In that case, you would start them on a multi-drug regimen. And at 2 months, if your cultures remain negative, you would repeat their imaging at that point and assess any change in their symptomatology. And if those had improved, then you would consider that that patient has culture-negative tuberculosis, and you would go on and treat them probably for an additional 2 months with isoniazid and rifampin, so you could stop the pyrazinamide and ethambutol at that point, and you would treat them for a total of 4 months. If, on the other hand, their chest X-ray has not changed and their symptoms have not improved, you really need to, at that point, consider alternative diagnoses. However, if you finish and you stop their treatment at that point, you have also treated them for latent TB infection because they've been on both rifampin and pyrazinamide for 2 months. And although that's not a recommended regimen for LTBI, it's certainly one that's efficacious. So in summary, with culture-negative TB, a 4-month regimen of isoniazid and rifampin, especially with pyrazinamide and ethambutol for the first 2 months as well, has been shown to have a very low relapse rate. And there's really not much data on this. Maybe Dr. Talbot can tell us a little bit more, but GeneXpert may have some utility here as well. I have a couple of slides left to sort of give you a flavor of some atypical radiographic presentations that you may encounter. So lower lobe infiltrates. Again, generally with TB disease, we talk about upper lobe and cavitary infiltrates. However, sometimes we see lower lobe disease, and sometimes along with those lower lobe infiltrates or independent, you may have a lot of mediastinal adenopathy. This clearly is seen commonly in children with primary TB, but you could also see it in some adult populations, especially in HIV. Miliary or disseminated TB also is another presentation of tuberculosis that can sometimes be missed or under-recognized. Pleural effusions account for a fair number of the extra-pulmonary TB cases that we see, as we saw before. Rarely you can see masses, although this is really unusual. And then actually quite frequently in the older literature, cavitary TB would present with a pneumothorax. We certainly don't see it that often anymore, but it's still a possibility. So this is sort of a classic picture of classic radiograph of somebody with cavitary tuberculosis. This is a 31-year-old man from Ecuador with cough, night sweats, fevers, and weight loss. And as you can see, he's got bilateral upper lobe dense infiltrates as well as multiple cavities here, here, and here. So this is one that would most likely not be missed. This is, again, that 29-year-old physician with a dry cough for 2 months, and we already went over her chest X-ray, but this is what you may see in somebody with non-cavitary tuberculosis. Again, pretty distinctive, pretty suggestive of tuberculosis, but certainly not as clear-cut as the X-ray before this. So this is a patient who had a left lower lobe infiltrate here, with, on CAT scan, also a left-sided pleural effusion. And her story was that she had a cough and fever for 1 week. She had a history of advanced HIV. She was originally treated for a left lower lobe pneumonia and a pneumonic effusion, but didn't have any improvement. Her quantiferon was negative. Her sputum smears were negative. But ultimately her sputum, her pleural fluid, and her blood cultures even grew tuberculosis. And so in HIV, we can clearly see very atypical presentations of disease, and it needs to absolutely be on our radar screen. So this was somebody with disseminated TB as a complication of their HIV. This is a chest X-ray of a 59-year-old woman with dermatomyositis who was on corticosteroids. She presented to us with shoulder pain and an ulcerated tongue mass. And I'm not sure how well it's projecting, but on my screen, the X-ray here shows a lot of small nodules throughout the lung field, a little bit more on the right than on the left. Her tongue lesion was biopsied, and that was acid-fast positive on smear, and her culture also grew tuberculosis. This was her CT, where I think you can appreciate the very small nodules much better. And so this is a miliary pattern on both X-ray and CAT scan, and this was somebody with miliary or disseminated tuberculosis as a complication of her autoimmune disease and her therapy for her autoimmune disease. I believe this is my last slide, but here you see upper lobe cavities surrounded by infiltrate and a large left-sided pneumothorax, actually pushing the mediastinum to the right, so probably a tension pneumothorax. And this is the second X-ray is after his chest tube was placed, showing resolution of the pneumothorax, and again, a lot of left upper lobe disease as well. And this was a young man with sort of classic active tuberculosis with upper lobe cavities who developed a pneumothorax probably as a complication of one of those cavities. So my take-home points are that TB disease can obviously present in many different ways, and we have to be suspicious at all times, especially in certain risk groups. We should utilize infection control measures appropriately, and I'm not sure if I emphasize this, but certainly for patients suspected of having TB in the hospital, even if they're smear negative, if TB is highly suspected, that person should be kept in airborne isolation until you make a diagnosis and treat them. You should become familiar with the rapid tests that are offered in your region and recognize what their limitations may be. And then, of course, collaborate closely with primary care, subspecialists, your microbiologist, public health authorities, and TB experts. And thank you.
Thank you so much, Dr. Patrawala, for really setting the stage for us so well. I'd like to now turn the program over to Dr. Elizabeth Talbot from Dartmouth Medical School, and she is actually going to do a case presentation for us, and we'll get into some of the points that Dr. Patrawala had set up for us so well. Dr. Talbot?
Hello, everyone. I do think the stage has been set well by Dr. Patrawala for the difficulty in diagnosing and managing extrapulmonary disease. I have several hats, and the one that this case came to my attention while I was wearing was that of the Deputy State Epi and also TB Medical Advisor. So I may not have every last clinical detail that the clinicians out there may want, but I think that there's still useful illustration from these as a vignette. So we received, in the capacity of the health department, routine report of a suspect bacterial meningitis. So a infection control preventionist called us on February 27th to appropriately report that they were suspicious. They were managing a case of bacterial meningitis. We received the broad strokes of the case and probed a little deeper with some unexpected findings. So this patient was a 19-year-old male from China with fever, headache, weakness, photophobia, nausea, vomiting, and a suggestive CSF. The patient was a student at UNH, and the targeted question to us was, would we provide prophylaxis for this patient's girlfriend and more broadly through the school system. We obtained the history from the reporter that this patient also had within their medical history 2 months prior to admission a hospitalization at the same institution for a right lower lobe pneumonia, which was also associated with an effusion. Diagnostics at that time did not disclose a bacterial pathogen, and an AFB smear was done on the pleural fluid, and that was negative. HIV test was also done and negative, although he did not endorse HIV risk factors. He received 2 weeks of a fluoroquinolone antibiotic and was discharged with the report that his cough had improved. He then went on Christmas vacation to his home in China, and during that time he apparently relapsed. So this is now 1 month prior to the current report. He was hospitalized for several weeks again. He reported that he had been at that time investigated for tuberculosis. The only method that was used for that we're aware of is TST. He wasn't able to report any more detail, but his TST was reportedly negative at that time. He again received a routine antibiotic, and his cough improved, and he was discharged to return back to New Hampshire for continuation of school. So details around this episode include that approximately 10 days prior to admission, so following those 2 episodes of pneumonia, he reported to the ED with nonspecific symptoms. He was not able to report fever, night sweats, anything, but just that something was wrong. He again came back to the ED, the same ED, on the 18th and again the 20th, saying he just didn't feel well. He was given azithromycin. On February 24th, he now presented for the 3rd time with headache, fever, weakness, and photophobia. So his syndrome has now declared itself as consistent with a meningitis. He was admitted. He had a head CT that showed no acute intracranial abnormality. Without contrast, this was done in order to safely perform the lumbar puncture, which showed a very low glucose, a very high protein, a moderate WBC count of 370 that were 70% PMNs. There was no bacterial growth, and an AFB was not done on that specimen. He was started on IV Cipro, and I am not sure why that drug was chosen, and he was reported to be promptly improving on that regimen, and hence the report came to us as a suspect case. I want to show you those 3 slides again with this big obnoxious triangle with the exclamation point to say that we had some red flags, so to speak. So this is the same slide that you saw at the beginning. So the suspect report, the patient was from China, and we were asked about prophylaxis. We saw the demographic of his birth in a high TB incident setting to be a red flag. Also, of course, the history of having had 2 recent pneumonias that defied routine bacterial identification seemed to us a red flag also, atypical for a presentation in a healthy person for bacterial meningitis. And then, as I imagine you've identified as well, the LP results were a red flag for the potential that this could have been Mycobacterium tuberculosis bacterial meningitis, because classically it does present with low glucose, high protein, a moderate WBC, and usually a lymphocytic predominance, but in this case a predominance of PMNs. So we asked the question of the reporting clinicians, could this be TB meningitis? And because we could not exclude, based on this history, we, as a health department, became involved to assist navigating that first CSF sample to MTB complex probe and AFB investigation. The patient did poorly in the hospital. He became confused. He was noted to be asymmetrically weak, and he developed seizures. His sodium was normal throughout, his serum sodium, but he required transfer to the ICU for control of his seizures. Days later, they obtained a second CSF, and in this case, the AFB was smear positive. This isolate was sent to the CDC for prompt sensitivity testing through molecular methods, because China does have a considerable rate of drug-resistant TB. March 6th, that first CSF specimen that was diverted shows positive by GenProbe for MTB complex, and that specimen was smear and to date culture negative. And these were the events that prompted the clinicians to start rifampin, isoniazid, pyrazinamide, and ethambutol. They also started steroid and had to use anti-epileptic drugs as well. Because he continued to deteriorate with regards to his mental status, he was transferred to Man's Greatest Hospital in Boston. Note that the initiation of anti-tuberculosis therapy was 17 days after his presentation to the emergency room and 11 days after the admission. So it seemed as though a considerable time had elapsed. This is an MRI that illustrates his findings, which were somewhat classic in terms of pathology in the basilar region of the brain and also hydrocephalus. There was diffuse leptomeningeal enhancement, which is only consistent for having a meningitis. So going forward, I'm going to include this little New Hampshire symbol as we come back to our case during the general comments about TB meningitis, but let me say that his course was complicated, so much so that on essentially 2 weeks into his RIPE therapy, the clinicians elected to add moxifloxacin and amikacin. They conducted a third lumbar puncture, which was, again, smear positive. In the meantime, we got results back regarding the isolate being pan-sensitive, so this was a great relief. He developed 3 weeks into therapy new cranial nerve deficits, which resulted in debilitating double vision and balance problems. And because his course seemed complicated and not going in the right directions, his family came from China and returned him with them. Of note, the clinicians who had agreed to receive him in China requested that the U.S. clinicians send enough medication with them to complete his course because they did not trust the quality of their local medications, incidentally. I did some investigation for the purpose of this presentation and had several confirmations that he has returned to an apparently normal neurologic function after this time, but it certainly wasn't certain that's the direction he was heading. So in clinical summary, he had, this is 2 unexplained pneumonias in an otherwise healthy young adult from China. He presented with nonspecific but perceived urgent symptoms over 10 days ahead of a presentation that suggested strongly tuberculous meningitis. And tuberculosis therapy was started more than 2 weeks after presentation, and then 2 weeks later, additional meds were added, and his diagnosis was confirmed by probe, smear, and eventually culture. So I am going to restrain concluding comments to the diagnosis of TB meningitis, and as tempting as it is to talk about epidemiology and treatment and others, that's what we'll talk about because that's often what we're confronted with. So the pathogenesis helps us to understand better the approach to diagnosis. So a TB bacteremia can occur either in primary or reactivation tuberculosis disease. And during that bacteremia, subependymal tubercles, which are also called rich foci, establish. These rupture after some amount of time into the subarachnoid space and lead to meningitis. The pathology associated with this pathogenesis is mostly localized to the base of the brain, where this dense gelatinous exudate develops surrounding the arteries and the cranial nerves, and this can result in hydrocephalus, vasculitis, which then goes on to infarction and hemi or quadriplegia. There's a very nice review of the tuberculous meningitis in the New England Journal several years back that I'd commend to your reading. We want to talk about TB meningitis outcomes because they compel us toward making an efficient diagnosis. So using the same reference and many others, TB meningitis is thought of in 3 clinical stages of presentation. You can present lucid with true meningismus or in a paralytic phase. And depending on what stage the patient presents, this predicts mortality, not surprisingly higher with advancing stage of disease. Our patient, by the way, was rather classic with regards to having had a 2 to 3 week lucid phase that was non-localizing, and then a classic meningitic phase progressing fairly rapidly to seizure and paresis. There are many studies of outcome where a third to a half of patients have a complete neurologic recovery, and about a third who do survive it have residual severe neurologic defects such as hemiparesis, blindness, and seizure disorder. So again, we're really compelled to try to make this diagnosis as efficiently as possible. One prognosis study that brings us back to our patient is one done in Taiwan. They observed 41 adults, some of whom were immunocompromised, and had a fairly lower mortality with a very high morbidity, and they were able to identify that those who had an AFB positive CSF appeared to have a worse prognosis, suggesting more multivascular disease. And the reason I like this study is that it helped me to understand that it's not unusual for patients to get worse during therapy. So fully half of the patients in this study got worse within the 2 to 4 weeks after having started effective therapy. So that reminds me of our case. In another prognosis study, about 50 adults and children with TB meningitis, they looked at predictors of outcome, and unfortunately our patient had several bad markers of outcome here. So stage of disease was advanced. He had focal weakness, cranial nerve palsy, hydrocephalus, and he had a delayed treatment defined as 2 weeks or more. So let's make the diagnosis quickly. I'm sure you're familiar with sending CSF for AFB smear and culture and examining with an eye toward identifying a lymphocytic pleocytosis, elevated protein, depressed glucose. We all struggle with a low sensitivity for an AFB stain, and this is a pretty big range reported, 10 to 60% sensitive for a single CSF specimen. In studies looking at, well, how do you get to be on the 60% side of things? You let your laboratorian know that you're serious about this potential diagnosis, because the longer they look, the more likely they are to see in those who go on to eventually have culture-confirmed disease. TB culture has a sensitivity, again, a big range, 25 to 75%, but it's delayed out 2 to 6 weeks, as you're well familiar. It appears that culture is likely to be more sensitive with increased volume, but although that's intuitive, I was happy to see one study that looked and said that your yield on culture doesn't increase substantially after 6 mils. So you're not asking clinicians to just, draw as much as possible, but really to increase the volume to a reasonable amount, not necessarily more than 6 mLs. There are 2 other methods of examining CSF that I'd like to talk about just briefly, and that's GeneXpert, MTB-RIF, which is a Cepheid product driven to availability through the activities of FIND in Geneva and also CDC here in the U.S. This is automated real-time PCR. This is a major breakthrough with regards to our ability to diagnose tuberculosis within about 90 minutes. It also detects rifampin resistance within 90 minutes. So this is really a game changer for us in global TB control. The comment I would make about that is that the jury is still out. So there had been many small studies around the use of GeneXpert on extra-pulmonary specimens. This has been developed for sputum. So what about if you use urine? What about if you use CSF and pleural fluid and pericardial fluid, et cetera? So in a meta-analysis looking at many different sample types, sensitivity appeared to be about 80%, but a pretty big range. A more recent study, since some upgrades in the technology, in fact, look at more than 10,000 mixed population, pulmonary and extrapulmonary patients. Again, the sensitivity is not perfect, maybe in the 77% median. Specificity, however, is excellent and pretty tight, the range there at 98 to 99%. The variation is seen between populations, how the patients are selected, the type of extrapulmonary TB, how those samples are processed, and what the researchers consider as a reference standard, whether it's smear or culture. So I pulled out some selected studies that I thought might be relevant to this conversation. It is the last 3 that included CSF, but see pretty robust numbers of patients who are examined with regards to extrapulmonary detection using Expert. Sensitivity was variable, but specificity excellent. So I'd propose that we're waiting for more data, but we're considering Expert may wind up being a rule-in test. That is, if it's positive, you've made your diagnosis. So more to follow on the story of the use of the GeneXpert for extrapulmonary TB diagnosis. One comment really around adenosine deaminase, which comes up in diagnosis of extrapulmonary disease, including pleural fluid, pericardial fluid, and certainly CSF. So ADA, adenosine deaminase, simply reflects immune cell activity. There are several different kinds of ADA, and macrophages produce it when they're trying to stimulate the immune system to battle pathogens like TB, but not only TB. So in meta-analyses looking at the utility of ADA for extrapulmonary TB diagnosis, most studies show sensitivity maybe around 90%, but specificity is less than 90%. So it's hard to know how to use such a thing. And incidentally, our patient didn't have this done, so I'm not sure how that would have helped us. Imaging, of course, is often used. Chest X-ray can be useful if it shows old TB. That's going to certainly raise your suspicion for TB meningitis if you find an abnormal chest X-ray. Our patient had a normal chest X-ray. CT MRI of the head can demonstrate hydrocephalus, basilar exudates, and inflammation. Our patient had all three. There were no tuberculomas noted on our patient's imaging and no infarctions. So the Thwaites, I hope I'm saying that right, Thwaites score had been developed to take together risk factor studies and diagnostic studies to try to establish by multivariable analysis predictive features for TB meningitis. So this had been published in The Lancet in about 2002 and was developed in Vietnam in adults. So this select population, using the features shown in this table, age, younger being a lower value, the white blood cell count lower being a lower value, duration of illness lower, et cetera. The researchers were able to determine that if the score was less than or equal to 4, TB meningitis should be strongly suspected. Greater than 4 might be bacterial. Sensitivity and specificity in this first effort was 97 and 91%. So the specificity starts to be a bit of a problem for giving false positive, depending on the population you apply it to. I wanted to let you know our case, if you use this scoring system, had a score of -5, so clearly in the range that they would consider likely for TB meningitis. The same team validated their algorithm in this clinical walk-down way, which was pretty darn easy to use. They identified 205 inpatients in Vietnam and found a sensitivity of 99%. However, when other groups have tried to use this in different settings and different populations with and without CNS radiology available, they may have had different findings. So in this study in Morocco, where radiology was not routinely available, they came up with a different number that was clinically relevant and extended it to include serum sodium, since TB meningitis can result in an SIADH leading to hyponatremia. Our patient on this algorithm would have wound up with a prediction for bacterial meningitis, by the way. This Lancet consensus group took many of the evolving clinical predicting scoring systems and came up with this one, which is more complicated. There are 20 parameters in 4 categories, which include clinical, such as the duration of symptoms before presentation, the CSF criteria, the imaging results, and then whether the patient has evidence of TB elsewhere. The maximum score that can be achieved on this scoring system is 20. And based on whether imaging was used to come up with that score or not, you come with a diagnosis of definite, probable, or possible. Definite can only be achieved by microbiologic or nucleic acid amplification tests. And then otherwise you fall into a category of probable or possible. Our case fell into the range of 15, which, because imaging was available, would have been categorized as probable using this method. So in summary, diagnosing TB meningitis requires high clinical suspicion, especially because poor prognosis is linked to delays in diagnosis and treatment. In this case, I think you'll note that it was the health department who raised the specter of TB here, and in fact, I think health departments retain good TB diagnostic vigilance and can facilitate expeditious diagnosis. Clinical scores and algorithms are available, and in general, we still have to rely on presentation, risk factors, imaging, routine CSF exams, and we all look to the potential that GeneXpert offers us as a potential rule-in test. So I think that those are the comments I had, and I also thank those who invited me to present here our case from New Hampshire.
Thank you so much, Dr. Talbot, for that very interesting presentation, and if we have time at the end, we can certainly answer any questions that come up about that, or have you answer any questions that come up about that case. I'd like to now turn the last presentation over to Dr. Marie Turner and Dr. Catherine McGowan from Massachusetts, and they also will be presenting some very interesting cases about how some of the challenges and the pitfalls can relate to a delay in diagnosis. So, Dr. McGowan and Dr. Turner, I'd like to turn the program over to you.
We're presenting two cases that actually are currently under therapy that we thought were interesting. Both have a delay in diagnosis, although for slightly different reasons.
This is Dr. McGowan. Our first case is that of a 25-year-old American-born Cambodian male whose father had tuberculosis approximately 1 year previously. His parents were Cambodian, but lived for many, many years in Vietnam and traveled back and forth to Vietnam quite frequently. After his father was diagnosed with tuberculosis, there was a contact investigation accomplished by public health, but this patient was not screened because he was unavailable. He was going to college, he had a nighttime job, catering on the side. However, all other family members were indeed negative for tuberculin skin test.
And like many young men, even though he had symptoms for a number of months, he ignored them until he had a cosmetic symptom. So in January of 2013, he had a flu-like symptom and a dry cough. He didn't lose weight, but he did develop fevers, drenching night sweats, and cough. But it wasn't until May, 4 months later, when his sister said to him, you know, you have a great big lump on your head, which looks really odd. I think you need to have that taken care of.
So he then was seen in the emergency room, and a very large scalp mass was indeed palpated. And the physicians who evaluated him ordered plain x-rays of the skull. And here we see a large defect in the skull with large defect in the calvarium in the skull, and then this very large scalp mass. This is a CAT scan that was accomplished, which also shows this very large scalp mass eroding through his skull, the table of his skull, the calvarium.
This is an MRI film of the same issue, and you can see again that he has this very large collection here with dural enhancement. And actually, this is a fantastic film. It is a sagittal view, and you can see here that he has the cold abscess here. You can see it's going through the skull. This is an MR, so the cortex of the skull is this black line here. The marrow is represented by the white, the other side of the cortex black. So you can see this goes straight through, and then you can see that the dural line is actually thickened here, and the dura is quite irritated by this cold abscess, which appears to be going through the skull.
This next MR is just a different view, an axial view, which shows this large mass and a collection, and again, erosion through the table of the skull with enhancement of the dura. Here we see that there are actually 3 different soft tissue masses and bony masses with enhancement of the dura in multiple different areas. Now this is a coronal view, and here we have a soft tissue mass below the left orbit. Here's a sagittal view where we have a soft tissue mass below the right orbit.
And now we're back to CT, and you can see that the zygomatic arch here is eroded, as is the anterior wall of the maxillary sinus. You can see here, this is the inferior orbital ridge. You can see there's destruction of this bone as well. And what we saved for last is the chest x-ray. So what does the chest x-ray of this gentleman look like? And first of all, you can see he's quite a corpulent young man. And he has this pleural process here. He's got this perihilar infiltrate here. And if you look carefully and count ribs on this side, you notice that there's a rib, that part of his rib is missing here. So we have a gentleman with a large infiltrate, a pleural process, and something is chewing on his ribs in addition. Here's a CT, which doesn't add much, but you see the pleural process and you see the infiltrate with the suggestion of air bronchogram there.
Next, we move to his neck, plain films of the neck, and these vertebral bodies look okay, but C6 is totally destroyed. This area is C6. This vertebral body is totally destroyed. This is an MR of the neck area. You see, even though it looked normal on plain films, is involved. There's enhancement, and C6, the one that is totally destroyed, actually impinges on the cord.
Patient was then started on TB therapy. He was started on conventional TB therapy in an outside hospital with INH rifamycin PZA. He was transferred to our service, and we added moxifloxacin, amikacin/caprimycin, and cycloserine. He ultimately did grow pan-sensitive TB, and actually I should add that just today I was able to secure the correlation between his dad's TB and his, and in fact this is the same organism as his dad had a couple of years ago. Over the course of the next 2 months of IV capryomycin, we went from amikacin to Caprio. Caprio is our preferred drug here. He had partial or almost complete resolution of the cold abscess of the head. His thoracic and cervical pain improved. His headache, however, continued, so at that point we DC'd the cycloserine and his headache resolved. Here's his chest x-ray. We just saw him last week, and you can see he did not yet grow his rib back, but his infiltrate looks much better. And on his last visit again, which was 11/8, he had the visit before, he had been quite depressed and crying. We started him on Zoloft. By 11/8, the mass on the head was entirely gone. He had no side effects from the meds. He was on a somewhat unconventional dosage and a number of drugs, which is something, again, we like to do when there's a lot of disease. He was on boosted INH, boosted rifampin, ethambutol, and PZA, off cycloserine, capryomycin, and moxifloxacin. I should add that the diagnosis here was made both by sputum and rib biopsy, and that the boosted doses are based on serum drug levels, and that this gentleman is HIV negative, and his only risk factor is his exposure to his dad.
We'll move on to our next case, that of a 21-year-old female who was born in China. She came to the United States in 2009 to attend college at UMass. She had a positive tuberculin skin test of 16 millimeters upon entry to college. Her chest x-ray was negative, and she declined TB therapy, latent TB therapy. She felt well, went on about her business until December of 2012, at which time she developed a cough, a nagging cough. She went to student health. They did not obtain a chest x-ray, but treated her with a Z-Pak, or azithromycin, on 2 occasions. She said perhaps she was slightly improved. She felt improved enough to leave during Christmas break to go visit her family in China. While she was in China, her parents noted she was coughing all the time. They brought her to a local hospital, and at the local hospital, a chest x-ray and CAT scan were both accomplished, and you'll see those in just a moment. They were both abnormal. She did produce sputum. Her AFB smear was negative. She was told she likely had a conventional pneumonia. She was placed on an unknown type of antibiotic, but was told she did not have TB and that it was fine for her to return to the United States.
But we just recently were able to secure the films from China, and you can see that she has what looks like a middle lobe infiltrate here. Diaphragm appears to be clear. We were able to get a couple of cuts of the CAT scan, and you can appreciate here that this area seems to be clear. This lung, the left lung, has never really had an issue. You start to see some little nodularity in the area of the right middle lobe. As we go down, this becomes more pronounced, but it does appear to be limited to that area of the lung. And again, looking at her lower lobe, that seems to be uninvolved.
She returns to Boston. She continues to cough incessantly over the next 5 months. She had multiple visits with the mid-level healthcare provider at her PCP's office, and multiple chest x-rays as well as multiple CAT scans were obtained. She was also given multiple courses of antibiotics, including fluoroquinolones such as moxifloxacin and levofloxacin, augmentin, and azithromycin. She was placed on inhaled corticosteroids. This is her chest x-ray in April, and I think you can again see this, what appears to be right middle lobe involvement. We can see it clearly on the lateral. We can see it clearly on the lateral, that it's right mid-lung field involvement. And there is a chest CT. Again, we see the mid-lung involvement, but we're beginning to see involvement in other areas that were previously not involved. The lower lobe here appears to be involved. The mid-lung field, again, continues to be involved. And here we see, again, more involvement, lower lobe, continued involvement, mid-lung field. The opposite lung appears fairly spared. And here we see more extensive disease in the lower lobe and continued involvement of the mid-lung. There's several pictures here. We just wanted to show you the extent and the evolving involvement of the lower lung that was not present on the previous CAT scans that Dr. Turner showed you.
So by June, the patient was no better. She actually personally noted that there was a pulmonary physician across the hallway from her PCP, and she asked her doctor and her healthcare worker, gee, do you think I could go see the pulmonary physician? They were told it was not a good idea. Nonetheless, being a college kid, she did go to the pulmonary office, asked if she could be seen. They said yes. The appropriate consultation request was obtained, and 2 weeks later she saw the pulmonary physician. He repeated the CAT scan, which now is worse again, but he did the one thing that the earlier caregivers did not do, and that is they did an AFB smear, which was positive. And I'd like to point out at this point, going back to our first speaker, that the fact that she was AFB negative in China certainly did not mean she didn't have TB, and we see lots of TB which is smear negative. So that was the first opportunity missed in this individual. The pulmonologist makes a presumptive diagnosis of TB. She's immediately started the end of June on INH rifamycin PZA, but over the ensuing month, for a full month, she remains smear positive. Moxifloxacin then is started 8/8/2013. So what we should point out at this point is that most of the TB providers in the audience know that when you have a failing regimen, you never add one drug. Moreover, this is a drug that this woman has seen before, because she's had multiple courses of antibiotics. So here's her June 2013 chest CT, and you see already here, this looks like superior segment of lower lobe. She's starting to develop disease. She has more disease, still has disease in the middle lobe. She also has some bronchiectasis here, which is quite evident. And as I'm just going to go down these slices, you can see she has more and more involvement of that lower lobe. So this is a very significant departure from her earliest film.
So 2 weeks after initiation of the moxifloxacin, her AFB smears do indeed become negative. However, her cultures are growing both Mycobacterium avium complex as well as Mycobacterium tuberculosis. And we had great difficulty obtaining sensitivities because of the MAC overgrowth. However, her chest x-ray is evolving and worsening. She had documented low serum drug levels of rifampin and ethambutol, and she was then referred to Lemuel Shattuck Hospital for evaluation in September. Should we add additional drugs, or should we await the sensitivities? The sensitivities we knew were going to be coming along fairly soon. We just decided to continue INH, rifampin, ethambutol, and PZA, as well as moxifloxacin, and await the sensitivities, which returned about 9 or 10 days later. And what we found was that there was resistance to INH at all levels. There was resistance to rifampin, ethambutol, and ethionamide. The PZA susceptibility is still pending. However, she was sensitive to some second-line drugs, cycloserine, capreomycin, and ciprofloxacin. So we're again left with more questions as to how do we treat at this point. We advised the patient and convinced her to be admitted to Lemuel Shattuck Hospital, where we initiated intravenous capreomycin, to which we knew she was sensitive. We continued the moxifloxacin as she was sensitive to this initially, but we were hesitant about this. We were not convinced she would remain sensitive. We continued the PZA pending the susceptibility testing. We added cycloserine as well as linezolid, and actually the patient did seem to improve while she was hospitalized with us at our institution. She tolerated the medications very well. She was only in for about a week. And then we discharged her to home, arranged for an IV infusion company to administer the capreomycin Monday through Friday for the next several weeks.
And because we were anxious about her, we did repeat another x-ray 2 weeks into TB treatment, which probably is much too short a period of time to see any real change, and in fact it was unchanged. However, at that visit, we also had the additional information that now her initial sputum was also PZA resistant. So what that meant was at the point that the Moxie was added, she essentially for 6 weeks was on Moxie as monotherapy, and now we will discontinue her PZA. So the changes we made at that point were we stopped the PZA, obviously, since she appeared to be resistant, and we thought about another drug to add. There weren't many at this point, so we decided to start Passer. Now, in Massachusetts, I don't think certainly not on her specimen, we didn't have any first-line testing for Passer, so this was pure faith. But in the meantime, we sent out the linezolid to see if that was sensitive, and in fact it was. We sent it to an outside lab. So at that point, we knew she was on drugs, capreomycin, cycloserine, and linezolid that she was sensitive to. We didn't know about Passer, and in terms of Moxie, we think she was sensitive initially, but we were concerned that she may not still be. Her AFB culture from 9/9/2013 was growing, so we asked the lab to repeat the sensitivities, and we're awaiting Moxie sensitivities from that. But they continue to have the same issues, and that is that MAC and MTB are growing at the same time, so they literally are picking out the colonies of MTB for sensitivity. One thing which became apparent, one thing which came to light during the course of our treating her for that month was that the public health nurse who was going out to the house said, you know, her apartment is kind of moldy. So we asked her in great detail, was this a subterranean basement apartment, first floor apartment? I never got a good take on that, but I said, well, she has so much MAC growing. She does have bronchiectasis. Maybe there's a source within the house. So we had her culture her shower head and culture the kitchen faucet. Both grew MAC after 7 days, so after a relatively short interval. And the question then came out again, how do we treat the MAC? Do we simply change her shower head, change the filter on her faucet in case MAC is a real pathogen and in case there's an environmental source? Or do we actually go ahead and treat her for Mycobacterium avium intracellulare? And, you know, if we do we do MAC sensitivities, which would be a send-out for our lab? So far, what we've opted to do was just change the shower head and the filter on the faucet, and we are reculturing the water sources in her house. The last problem we've had with her is that her platelets fell to 110,000. They'd previously been about 150 to 175, and we thought this might be a marker of linezolid, since we know linezolid goes to the marrow, and platelets are often the first thing affected. I'll tell you what we opted to do is we opted to just sit on it since we were concerned about the extent of her disease and the progression, and so far her platelets have not fallen further, so we seem to be okay. So I think in terms of this case and with respect to delay, one could ask the question, would it have made a difference if back when she started school as a freshman, if she'd actually received LTBI therapy? And I think that's that's very debatable. Certainly the delay from December till almost July was really inexcusable, and somebody should have thought that this young woman who was born in China, who had recurrent pneumonia, that TB was certainly very high on the differential. The first patient, in terms of delay, I believe that a lot of that was at the level of the patient. He just did not think it was worthwhile going to see a physician until he had a big lump on his head, and his sister kind of laughed at him. It is interesting that he matches his dad, so in retrospect, although I think public health did a great job trying to assess all the contacts, it is unfortunate he was missed in that first contact investigation. So I think I'm done.
We're done.
Thank you so much. I'd like to finally post Dr. Patrawala's final take-home point slide once again to remind people about the keeping of a high index of suspicion, particularly in high-risk groups, and about the approach that she had mentioned at the beginning to kind of look at the entire picture when considering your diagnosis of tuberculosis. And that I'd like to thank all of the speakers for really illustrating those points extremely well with the cases that they demonstrated today. Just a reminder that the Global Tuberculosis Institute provides a medical consultation to members of the Northeast region, so you can call 1-800-4TB-DOCS if you have questions. And for those of you that are outside of our region, certainly consult with your appropriate regional training and medical consultation center, as well as your state or regional TB program. Thank you very, very much for your participation and for rich presentations today, and have a good afternoon.